Condition: infective endocarditis. Background: bacterial or fungal infection affecting the endocardium, including native or prosthetic valves. Staphylococcal infection is currently the leading cause on native valves, prosthetic valves, and cardiac device infection. Other organisms causing IE on native valves include viridans streptococci, coagulase-negative staphylococci, Streptococcus bovis group, currently Streptococcus gallolyticus or Streptococcus infantarius, and Hasek group. Other organisms causing IE on prosthetic valves include Corynebacterium species, Streptococcus species, Enterococci, Enterobacteriaceae, Pseudomonas aeruginosa, Candida albicans, and other fungi. Clinical features: IE should be suspected in any patient with a new or increased regurgitant heart murmur along with signs or symptoms of infection or bacteremia, fever of unknown origin. Diagnosis: the diagnosis of IE is made using the Duke criteria. Duke's criteria: definite diagnosis. Presence of any pathologic criteria or 2 major criteria or 1 major and 3 minor criteria or 5 minor criteria. Major criteria: positive blood culture for typical infective endocarditis organisms, S. viridans or S. bovis, Hasek organisms, S. aureus without other primary site, Enterococcus, from 2 separate blood cultures or 2 positive cultures from samples drawn and GT 12 hours apart, or 3 or a majority of 4 separate cultures of blood, first and last sample drawn 1 hour apart. Echocardiogram with oscillating intracardiac mass on valve or supporting structures, in the path of regurgitant jets, or on implanted material in the absence of an alternative anatomic explanation, or abscess, or new partial dehiscence of prosthetic valve or new valvular regurgitation. Single positive blood culture for Coxiella burnetii or antiphase 1 IgG antibody titer and GT1:800. Minor criteria: predisposing heart condition or intravenous drug use, temperature and GT38. C. 11.4. Vascular phenomena: arterial emboli, pulmonary infarcts, mycotic aneurysms, intracranial bleed, conjunctival hemorrhages, Janeway lesions. Immunologic phenomena: glomerulonephritis, osselar nodes, Roth spots, microbiological immunologic phenomena: glomerulonephritis, osselar nodes, Roth spots, rheumatoid factor. Microbiological evidence: positive blood culture but does not meet a major criterion as noted above, or serological evidence of active infection with organism consistent with endocarditis, excluding coagulase-negative staphylococcus, and other common contaminants. Although transoesophageal echocardiography requires greater operator training and sedation of the patient, it should be regarded as an acceptable primary diagnostic test without previous transthoracic echocardiography in certain clinical situations. Intermediate or high pretest probability of endocarditis, particularly in patients with S. aureus bacteremia, patients with prosthetic valves, and evaluation for complications of endocarditis, such as intracardiac abscess, valve perforation, or fistula formation. Management requires a collaborative, multidisciplinary approach, ideally by an endocarditis team composed of, at the minimum, an infectious diseases physician or clinical microbiologist, cardiologist, and cardiac surgeon. Principles of antimicrobial use: must be given intravenously except in rare cases, example Coxiella burnetii i.e. Beta-lactams is most frequently considered first-line therapy. Patients with immediate hypersensitivity to penicillin should be strongly considered for desensitization, preferred over a prolonged course of vancomycin. Therapeutic drug level monitoring is recommended. Duration of antimicrobial therapy is typically from 4 to 6 weeks. Stable patients who have completed at least 2 weeks of in-patient treatment may be discharged for community-based parenteral antimicrobial therapy. Switching to an oral antibiotic after initial intravenous therapy may be appropriate for some patients, especially if managed by a multidisciplinary team. Gentamicin is recommended as part of initial empiric antimicrobial therapy for native valve, prosthetic valve and cardiac implantable electronic device associated endocarditis, but often continued for confirmed streptococcal or enterococcal, i.e. with regular drug blood level monitoring. Gentamicin may be combined with vancomycin if required. Duration of antimicrobial therapy after valve surgery for infective endocarditis. If valve culture is negative, antibiotics are to be completed based on the recommendation, or for at least a further 2 weeks, whichever is longer. If valve culture is positive, antibiotics are given for 4 to 6 weeks. Criteria for community-based parenteral antimicrobial therapy for infective endocarditis, after initial inpatient therapy. Medically stable and responding to therapy. No medical contraindications for the proposed approach. Afebrile for at least 72 hours with negative blood culture results. No evidence of heart failure, or small vegetations. No evidence of heart failure, or stable heart failure. Small vegetations, example and LT 10 mm, and no intracardiac abscess or paravalvular extension on transoesophageal echocardiography. No new cardiac conduction abnormalities. No neurological findings that could result from cerebral embolism or infected, mycotic, aneurysm. No uncontrolled extracardiac infection. Continued supervision by a cardiologist and an infectious diseases physician or clinical microbiologist. Empiric therapy for native valve infective endocarditis. The 3-drug regimen includes benzylpenicillin 1.8 g for every 4 hours plus flucloxacillin 2 g for every 4 hours plus gentamicin, 7 mg per kilogram initial dose if with septic shock without kidney impairment, 4 to 5 mg per kilogram if without septic shock and with septic shock and kidney impairment. For patients with immediate non-severe or delayed non-severe penicillin allergy, the 3-drug regimen includes cefazolin 2 g for every 8 hours, or every 6 hours if with septic shock, plus vancomycin 25 to 30 mg per kilogram for loading dose plus gentamicin 4, regimen same as above. For patients with immediate severe penicillin allergy, the cefazolin regimen can still be used after careful consideration of the risks and benefits, otherwise, gentamicin plus vancomycin is used. Empiric therapy for prosthetic valve and cardiac implantable electronic device associated infective endocarditis. The 3-drug regimen includes flucloxacillin 2 g for every 4 hours plus vancomycin 4, regimen same as above. For patients with immediate non-severe or delayed non-severe penicillin allergy, flucloxacillin is replaced by cefazolin 4, regimen same as above. For patients with immediate severe penicillin allergy, the cefazolin regimen can still be used after careful consideration of the risks and benefits, otherwise, gentamicin plus vancomycin is used. Condition: pericardial diseases. Pericarditis. Background and clinical features. Acute pericarditis. Viral etiology: in most cases, prognosis is generally good. Chest pain is the most frequent symptom, sharp and severe, and worsen with recumbent position, helps differentiate it from other causes. Diagnosis is most often confirmed by 2 of 3 classic findings, but if pericardial effusion is evident on echocardiography and unexplained, only one of these findings is necessary. Chest pain, often with pleuritic component. Friction rub. Diffuse ST segment elevation on electrocardiography. May follow acute myocardial infarction, 1 to 3 days, or delayed, and GT 1 week to several months. A pericardial friction rub is virtually pathognomonic, best auscultated at the left sternal border during suspended respiration while the patient is leaning forward. Epicardial inflammation causes upwardly concave ST segment elevation in all leads except AVR. An ST segment elevation to T wave amplitude ratio of superscript 30.24 in lead V6 is reliable in distinguishing pericarditis from early repolarization. PR segment depression in the limb leads, particularly lead 2, or precordial leads, and elevation in lead AVR, may accompany ST segment elevation. Myopericarditis. Coexistent acute pericarditis with myocarditis. Evidence of myocardial injury unrelated to myocardial infarction. Electrocardiography shows regional concave downward ST segment elevation akin to myocardial infarction, new segmental or global left ventricular dysfunction, and elevated cardiac markers. Prognosis is generally good except when there is significant myocardial injury. Recurrent pericarditis. Likely autoimmune. Recurring bouts of acute pericarditis over 2 to 5 years. Features that confer a high risk of recurrent pericarditis include failure of an acute episode to respond to aspirin or nonsteroidal anti-inflammatory drugs and previous treatment of acute pericarditis with corticosteroids. Diagnosis is made by recurrent chest pain and one of the following: fever, friction rub, characteristic electrocardiographic changes, pericardial effusion, or an elevated inflammatory marker. Diagnosis: in acute pericarditis and myopericarditis, physical examination should include assessment for cardiac tamponade and heart failure. Echocardiography is an essential adjunct. In acute pericarditis, serial electrocardiography to monitor evolution of ST segment and T-wave changes to help differentiate it from acute myocardial infarction. Chest X-ray to exclude other causes. Inflammatory markers are elevated, normal results argue against the diagnosis. Cardiac biomarkers are elevated in myopericarditis. Targeted investigations depending on the etiology: uremia, bacterial infections, autoimmune diseases, human immunodeficiency virus infection, tuberculosis, although viral titers are not usually obtained because they have a low diagnostic yield. Chest computed tomography scan and magnetic resonance imaging may be used to evaluate the pericardium. Management. Directed at the specific etiology. The goals of treatment are pain relief and prevention of recurrence, tamponade, and constrictive pericarditis. Outpatient treatment is safe and feasible in adult patients with small pericardial effusions, and LT1CM, uncomplicated by myocarditis, pyogenic infection, sepsis, tamponade, recent trauma, suspicious malignancy, coagulopathy, or hemodynamic instability. Inpatient management is required if a specific treatable cause is identified, or in any of the following situations: high fever, and GT38. Subacute course, symptoms over several days without a clear-cut acute onset. Large pericardial effusion. Cardiac tamponade. Failure to respond within 7 days to aspirin or nonsteroidal anti-inflammatory drugs. Anti-inflammatory medications are the primary treatment for acute pericarditis, with the goals of relieving chest pain, fever, and inflammation. Colchicine plus anti-inflammatory drug improves remission rates of pericarditis at 1 week and reduces recurrences rates. Usual regimen is colchicine 500 mcg orally twice daily, once daily if and LT 70 kg, for 3 months, tapering not required, plus aspirin 750 to 1000 mg orally every 8 hours for 1 to 2 weeks, usual duration, then reduced to 250 to 500 mg every 1 or 2 weeks, or ibuprofen 600 mg orally every 8 hours for 1 to 2 weeks, usual duration, then decreased by 200 to 400 mg every 1 or 2 weeks. Pericardial effusion without cardiac compression. Background and clinical presentation. Etiology is almost the same as the causes of pericarditis. Associated with hypothyroidism. Muffled heart sounds and dullness percussible beyond the apex. Diagnosis. Electrocardiography is nonspecific, but QRS voltage may be reduced compared with previous tracings, or electrical alternans may be present with large effusion. Echocardiography is diagnostic and is helpful in determining the hemodynamic significance of the effusion and in following resolution or accumulation. Cardiac computed tomography and magnetic resonance imaging may identify a pericardial effusion but should not be used for diagnosis unless a more detailed investigation of the anatomy is necessary, suspected pericardial malignancy or constriction. If clinical cause fails to reveal an obvious cause, it is unlikely that extensive laboratory tests will yield a diagnosis. Check full blood count, electrolyte panel, and test for blood urea nitrogen and serum creatinine, thyroid-stimulating hormone, anti-nuclear antibodies, and tuberculin skin response. Pericardiocentesis and pericardial biopsy aids in diagnosing serious causes of pericardial effusion, such as bacterial infection, malignancy, and tuberculosis. Management. In a stable patient with chronic idiopathic pericardial effusion, no specific therapy is needed. Perform pericardiocentesis if it does not resolve in 3 months. Occult hypothyroidism should be excluded. Echocardiography is useful to monitor for regression or progression of the effusion and for signs of increasing intrapericardial pressure as a harbinger of cardiac tamponade. Infected pericardial effusion should be drained with antibiotic coverage. Prolonged catheter drainage, pericardial sclerosis, surgical decompression, and percutaneous balloon pericardiotomy are options for malignant pericardial effusion. Cardiac tamponade. Background and clinical features. Accumulation, rapidity of fluid accumulation, of pericardial fluid with resultant increase in intrapericardial pressure. Signs and symptoms include dyspnea, tachycardia, jugular venous distension, hemodynamic instability, and hypotension. Both circumferential, mostly, and loculated effusions can cause tamponade. Can present acutely, subacutely, or as low-pressure tamponade. Pulsus paradocus supports the diagnosis of tamponade but is not always present nor pathognomonic. Diagnosis. Echocardiography is diagnostic. Diastolic invagination of the right atrial or ventricular wall, accentuated respiratory fluctuations in peak transvalvular velocities, and distended inferior vena cava. Management. Conservative therapy with serial hemodynamic monitoring and echocardiography, volume resuscitation, and treatment of cause for early or subacute tamponade. If with hypotension, volume resuscitation, and vasopressors. If ventricular function is impaired, inotropic support or an intra-aortic balloon pump may be needed. Drain by pericardiocentesis or surgery. Surgical drainage is preferred for malignant effusions and for aortic dissections that rupture into the pericardial space. In patients with tamponade and respiratory distress, mechanical ventilation and sedation should be avoided, reduced venous return and compensatory sympathetic drive, respectively. Constrictive pericarditis. Background, clinical features, and diagnosis. Impaired filling resulting from resistant ventricular diastolic expansion by a stiff pericardium. Symptoms include dyspnea, fatigue, and peripheral edema. Signs include jugular venous distension with Kussmaul sign, pericardial knock, hepatomegaly, and ascites, no pulmonary congestion. AF is present in 20% of patients. Differentiation between constrictive pericarditis and restrictive cardiomyopathy is important because surgical pericardiectomy may be curative with the former. Differentiation of constrictive pericarditis from restrictive cardiomyopathy. Findings. Physical examination. Constrictive pericarditis. Restrictive cardiomyopathy. Physical examination. Point of maximal impulse. Not detectable. Often detectable. Electrocardiography. Presence of left or right bundle branch block. Not supportive. Constrictive pericarditis. Restrictive cardiomyopathy. Supportive. Supportive. Presence of left or right ventricular hypertrophy. Constrictive pericarditis. Not supportive. Restrictive cardiomyopathy. Supportive. Chest radiography. Pericardial calcification. Constrictive pericarditis. May be present. Restrictive cardiomyopathy. Absent. Echocardiography. Presence of left ventricular hypertrophy. Constrictive pericarditis. Absent. Restrictive cardiomyopathy. Present. Reduced tissue Doppler velocities. Constrictive pericarditis. Absent. Restrictive cardiomyopathy. Present. Accentuated drop in peak left ventricular filling during inspiration. Constrictive pericarditis. Present. Restrictive cardiomyopathy. Absent. To and fro diastolic motion of ventricular septum. Constrictive pericarditis. Present. Restrictive absent. Increased pericardial thickness. Present in 80%. Absent. Hemodynamic right and left heart catheterization. Elevated and equalized diastolic left and right ventricular pressure. Present. Absent. Left and right ventricular systolic pressure changes with respiratory cycle. Discordant. Concordant. Laboratory testing. B-type natriuretic peptide. Normal or minimally elevated. Markedly elevated. Management. Judicious use of loop diuretics. Rate control in AF. Transient constrictive pericarditis occurs and may resolve spontaneously or after anti-inflammatory therapy, typically within 6 months. Causes include viral infection, connective tissue disease, trauma, malignancy, pericardiotomy. In stable patients, 2 to 3 month trial of anti-inflammatory therapy is warranted before proceeding to surgical pericardiectomy. Constrictive pericarditis from TB resolves with anti-CACHs for 6 months. Pericardiectomy is the only effective treatment for chronic constrictive pericarditis, functional class 2 or 3. Condition, common arrhythmias, atrial fibrillation. Background. Incidence is 2 to 4% in Australia. Most common cause of recurrent arrhythmia and causes significant economic burden. Re-entry is the mechanism of impulse formation. Classifications. New onset or first diagnosed atrial fibrillation. No previous diagnosis of atrial fibrillation. Paroxysmal atrial fibrillation. Episodes of self-terminating atrial fibrillation, usually within 48 hours, although may last up to 7 days. Persistent atrial fibrillation. Episodes lasting gt 7 days. Long-standing persistent atrial fibrillation. Continuous atrial fibrillation lasting for gt 1 year or longer, and it is decided to use rhythm control. Permanent atrial fibrillation. If the patient opted to remain on this rhythm and not attempting rhythm control. A patient who decides to undergo rhythm control later would be reclassified as long-standing atrial fibrillation. The risk of thromboembolism is similar for all types of atrial fibrillation. Risk factors include heart failure, acute coronary syndrome, hypertension, valvular heart disease, myo and pericarditis, Wolff-Parkinson-White syndrome, diabetes mellitus, obesity, obstructive sleep apnea, and hyperthyroidism. Clinical features. May present with palpitations, lightheadedness or dizziness, dyspnea, exercise intolerance, chest pain, and loss of consciousness. Loss of atrial kick may lead to a drop in cardiac output and decreased coronary perfusion. It is not uncommon for some patients to be asymptomatic, thus, opportunistic screening among elderly patients, and GT 60 years, is recommended. Diagnosis. Characterized by the classic axiom, irregularly irregular rhythm with variation in both interval and amplitude from R wave to R wave is always atrial fibrillation. Refer to the National Heart Foundation of Australia and Cardiac Society of Australia and New Zealand, Australian Clinical Guidelines for the Diagnosis and Management of Atrial Fibrillation 2018, see references folder. Management. Refer to the National Heart Foundation of Australia and Cardiac Society of Australia and New Zealand, Australian Clinical Guidelines for the Diagnosis and Management of Atrial Fibrillation 2018, see references folder. Atrial flutter. Background. Impulses take a circular course around the atria, setting up the flutter waves. Re-entry is the mechanism of impulse transmission. Clinical features. Like atrial fibrillation. Diagnosis. often with a 2:1 atrioventricular block and a regular ventricular rate of 150 bpm, may have a greater degree of atrioventricular block giving a rate of 100 bpm, 3:1, or 75, 4:1. Management. Overall management is similar to atrial fibrillation. Relatively insensitive to antiarrhythmic agents, thus, electrical cardioversion is performed earlier in atrial flutter than in atrial fibrillation. Catheter ablation is considered in recurrent atrial flutter. Supraventricular tachycardia. Background. Rhythm is initiated above the ventricle. Atrial fibrillation and flutter are technically supraventricular tachycardias, and thus, the term usually refers to the most frequent paroxysmal supraventricular tachycardias, namely, atrioventricular non-reentrant tachycardia, atrioventricular reentrant tachycardia, and atrial tachycardia. Clinical features. Symptoms include rapid heart rate, palpitations, pounding sensation in the neck, fatigue, chest pain, shortness of breath, lightheadedness or dizziness, and diaphoresis. Diagnosis. Normal appearing and measuring QRS complexes, usually narrow but may be wide in bundle branch blocks or when there's conduction down a bypass pathway. Heart rate is usually 150 to 250 bpm. The T waves of the previous complex covers the P waves of the next complex. Management. Always assess for hemodynamic stability first. If stable, start with maneuvers that enhance the vagal tone, Valsalva maneuver and carotid sinus massage, the later avoided in elderly patients and those with vascular disease. If initial maneuvers fail, give adenosine 6 mg by rapid bolus, increased to 12 mg and 18 mg every 2 minutes if the initial dose is ineffective but well tolerated, or verapamil 5 to 10 mg for over 2 minutes followed by a second dose after 30 minutes if the initial dose is ineffective but well tolerated, or metoprolol tartrate 2.5 to 5 mg for over 2 minutes followed by a second dose after 10 minutes if the initial dose is ineffective but well tolerated. Calcium gluconate 1g for over 2 to 3 minutes may be given as pretreatment medication prior to verapamil to minimize the latter's blood pressure lowering effect without affecting its antiarrhythmic effect. Adenosine is relatively contraindicated in patients with acute bronchospasm. Verapamil should not be given to a patient with a wide complex tachycardia unless it's supraventricular in origin and should be avoided in patients with heart failure with reduced ejection fraction. Metoprolol should be used with caution in patients with heart failure with reduced ejection fraction, negative inotropic effect, and acute bronchospasm. If the above measures fail, subsequent options include direct current cardioversion, amiodarone, or overdrive pacing. If unstable, manage with synchronized cardioversion, 50 to 100 J. Prophylactic options. Infrequent episodes do not require prophylactic medications. Frequent episodes or the presence of Wolff-Parkinson-White syndrome requires referral to an electrophysiologist for further workup and possible ablation therapy, usually with failed medications. Medication options include atenolol, metoprolol, sotalol, verapamil, flecainide, if without structural or ischemic heart disease and given in combination with an AV nodal blocking agent, or amiodarone, if other medications and have failed and the patient is not a candidate for catheter ablation. Monomorphic ventricular tachycardia. Background. Impulse conduction is slowed around areas of ventricular injury, infarct, or ischemia, which serves as a source of ectopic impulses, irritable foci. Areas of injury can cause impulses to take a circular course leading to reentry phenomenon. Medications that prolong the QT interval can also cause ventricular tachycardia, example tricyclic antidepressants, procainamide, digoxin, some long-acting antihistamines. Clinical features. Monomorphic ventricular tachycardia can be asymptomatic, despite the widespread erroneous belief that sustained ventricular tachycardia always produces symptoms. Most cases will have symptoms of decreased cardiac output, example orthostasis, hypotension, syncope, exercise limitation. Untreated and sustained ventricular tachycardia will deteriorate to unstable ventricular tachycardia or ventricular fibrillation. Diagnosis. Key electrocardiographic finding is wide QRS complexes with similar morphologies or shapes. Superscript 3 consecutive premature ventricular complexes is ventricular tachycardia. Ventricular tachycardia and LT 30 seconds is non-sustained. Ventricular tachycardia superscript 3 30 seconds is sustained. Management. Management of acute sustained ventricular tachycardia. In general practice, patients must be immediately transferred to the emergency department. Always assess for hemodynamic stability first. If stable, antiarrhythmic drug options include amiodarone 300 mg for infusion over 10 to 20 minutes followed by 900 mg for infusion over 24 hours if required, first line, or lidocaine 1 mg per kilogram, usually 75 to 100 mg, for over 1 to 2 minutes followed by 4 mg/minute by 4 infusion for 1 hour then reduced to 1 to 3 mg/minute, second line. If medications fail, treat with cardioversion. If unstable, perform immediate cardioversion. Subsequent management of sustained ventricular tachycardia. Patients with structural heart disease are referred to a cardiac electrophysiologist for consideration of an implantable cardioverter defibrillator, improved survival but not recurrence, thus, still used with an antiarrhythmic medication. Patients without structural heart disease have a good prognosis and generally do not require implantable cardioverter defibrillator, but nevertheless referred to a cardiologist for further evaluation and management, consideration of beta blockers, flecainide, verapamil, or catheter ablation if recurrent. Management of non-sustained ventricular tachycardia. Only treated if there is prolonged hemodynamic compromise or significant symptoms. Medications include atenolol 25 mg up to 100 mg orally daily or metoprolol tartrate 25 mg up to 100 mg orally twice daily or flecainide 50 mg up to 150 mg orally twice daily or verapamil MR 180 mg orally up to 360 mg orally daily or amiodarone 200 mg to 400 mg orally thrice daily for 1 week, then twice daily for 1 week, then once daily, if symptoms are persistent or there is cardiomyopathy secondary to the non-sustained ventricular tachycardia. Consider catheter ablation if medical therapy fails. Torsades de points. Background. Unique subtype of polymorphic ventricular tachycardia. Specific pathophysiology of classic torsades. QT interval is abnormally long. Leads to increase in the relative refractory period, vulnerable period, of the cardiac cycle. Increased probability that an irritable focus will occur on the T wave, R-on-T phenomenon. R-on-T phenomenon often induces ventricular tachycardia. Most commonly occurs with prolonged QT interval from many causes including congenital anomaly, congenital long QT, medications, example tricyclic antidepressants, procainamide, digoxin, and some long-acting antihistamines, electrolyte and metabolic alterations, hypomagnesemia is the prototype, and acute ischemic events. Clinical features. Most patient will have symptoms of decreased cardiac output, i.e., orthostasis, hypotension, syncope, or exercise limitation. Asymptomatic, sustained, or stable torsades is uncommon. Usually deteriorates to pulseless ventricular tachycardia or ventricular fibrillation. Diagnosis. QRS complexes display a spindle node pattern, that is, the amplitude increases then decreases in a regular pattern, creating the spindle, with initial deflection at the start of the spindle, example negative, followed by the opposite, example positive, deflection at the start of the next spindle, creating the node. Management. If there's an underlying cause, immediate treatment involves addressing that underlying cause, i.e., withhold offending medications, correct hypomagnesemia and hypokaliemia. If the cause is congenital long QT, medications include metoprolol tartrate 25 mg up to 100 mg orally twice daily if required, or propranolol 10 mg up to 40 mg orally 3 to 4 times daily if required, together with referral to a cardiac electrophysiologist for consideration of implantable cardioverter defibrillator. If torsades coexist with bradycardia, atropine 0.5 mg up to 3 mg for every 3 to 5 minutes if required. Medications that may also be used to control bradycardia or drug-induced torsades include magnesium sulfate 50% solution 4 ml, 2g, by 4 infusion over 10 to 15 minutes followed by 1 to 1.5 ml, 0.5 to 0.75 g, by 4 infusion over 12 to 24 hours if required, first line, or isoprenaline 20 mg for repeated according to clinical response, followed by 1 to 4 mg per minute by 4 infusion, second line, or temporary transvenous pacing, paced at a rate of 90 to 100 bpm, third line, or lidocaine 75 to 100 mg. 4 over 1 to 2 minutes followed by 4 mg per minute by 4 infusion for 1 hour, then reduced to 1 to 3 mg per minute, if successful. Amiodarone and sotalol are avoided. Ventricular fibrillation. Background. Most serious rhythm abnormality. The ventricles consist of areas of normal myocardium alternating with areas of ischemic, injured, or infarcted myocardium, leading to chaotic pattern of ventricular depolarization. Common etiologies include acute coronary syndrome, untreated stable or unstable ventricular tachycardia, premature ventricular complexes with R-on-T phenomenon, primary or secondary QT prolongation, electrocution, and hypoxia. Clinical features: pulselessness, collapse, unconsciousness to death. Diagnosis. On electrocardiography, rate is indeterminate with no recognizable P, QRS, or T waves. Rhythm is indeterminate with a pattern of sharp up, peak, and down, trough, deflections. Amplitude, measured from peak to trough, is often used subjectively to describe ventricular fibrillation as fine, 2 to and LT 5 mm, moderate, 5 to and LT 10 mm, coarse, 10 to and LT 15 mm, and very coarse, and GT 15 mm. Management. Refer to the Australian Resuscitation Council Guidelines, see references folder. Condition: peripheral arterial occlusive disease. Chronic limb ischemia. Background: almost always due to atherosclerosis, fibromuscular dysplasia and vasculitis are very rare, and its underlying risk factors, that is, smoking, diabetes mellitus, hypertension, and dyslipidemia, with the first two as the strongest risk factors, associated with high absolute cardiovascular disease risk. Mortality rate is 2% per year and rates of non-fatal myocardial infarction, stroke, and vascular death are 5 to 7% per year. Clinical features: intermittent claudication, good prognosis overall. Cramping pain in the calf, thigh, or buttock, ulceration, gangrene, and foot pain at rest. Buttock claudication with or without impotence imply Leriche syndrome. Patterns of disease affecting the lower limb. Superficial femoral artery. Most common site of atherosclerosis or stenosis. Aortoiliac disease. Involves the lower aorta and common iliac arteries and external iliac artery. Combined disease. Significant disease of both systems. Common femoral or profunda artery and disease of the tibial arteries associated with diabetes. Diagnosis. Perform investigations to rule out possible causes and risk factors including diabetes mellitus, arteritis, anemia, infection including syphilis, renal diseases, and dyslipidemia. Electrocardiography to rule out concomitant ischemic heart disease. Pathophysiology is the same. Angiography remains to be the gold standard. Duplex scan is the simplest and most cost-effective. Contrast arteriography, digital subtraction arteriography, and color duplex imaging to assess the extent and location of stenosis and the quality of distal vessels. Arterial brachial index. Superscript 3:1 is normal, 0.9 to 0.6 is claudication, 0.3 to 0.6 is rest pain, 0.3 pounds or ankle systolic blood pressure, and LT 50 mmHg is impending gangrene. Management. Mainstay of treatment is like the management of atherosclerotic disease elsewhere. Encourage smoking cessation. Treat comorbidities, i.e., diabetes to glycemic target, hypertension preferably with angiotensin-converting enzyme inhibitors, and dyslipidemia with statins. Use of antiplatelets. Aspirin 100 to 150 mg orally daily or clopidogrel 75 mg orally daily. Dual antiplatelet therapy is not recommended in patients with stable peripheral arterial occlusive disease. Graduated walking or supervised exercise program. Silostazol or pentoxifylline may be used as a temporary bridge to improve symptoms and exercise tolerance. Percutaneous transluminal angioplasty. Benefit: stenting that is ideal for short stenosis in big arteries. Beneficial for iliac artery disease. Risk of complication is 2%. Surgical reconstruction. Extensive atheromatous disease with good distal runoff. Include above-knee femoral popliteal bypass, femoral-femoral crossover, and aortobifemoral grafts. Antiplatelets and anticoagulants help maintain patency. Sympathectomy. Relieve rest pain if revascularization is impossible. Amputation. Relieve intractable pain and death from sepsis and gangrene. Patient's decision on the background of failed conservative measures. Level of amputation must be high enough to ensure healing of the stump. Acute limb ischemia. Background. Medical emergency. Due to thrombosis in situ, emboli graft, or angioplasty occlusion, or trauma. Emboli usually arise from the heart, example infarcts, atrial fibrillation, or an aneurysm, example aortic, femoral, popliteal. Mortality rate is 22% and amputation rate is 16%. Clinical features. Presence with the 6Ps, that is, pallor, pulselessness, pain, paralysis, paresthesia, perishing cold. The clinical categories will be presented in the live lecture. Management. Emergency requiring urgent open surgery or angioplasty. If the occlusion is embolic, surgical embolectomy or local thrombolysis is performed. Anticoagulation with heparin. Unfractionated heparin 80 units/kg for loading dose followed by 18 units/kg/hour by intravenous infusion. Condition: venous thromboembolism. Venous thromboembolism, background. Involves a wide spectrum of thromboembolic conditions, ranging from distal deep vein thrombosis, through proximal deep vein thrombosis to pulmonary embolism. Must be documented by appropriate investigations, ideally performed before initiating treatment. Deep vein thrombosis. Background and clinical features. Many aspects of this disorder remain controversial. Potentially fatal disease process that is often silent or nonspecific and for which a wide range of diagnostic techniques is available, many with technical and interpretive limitations. In patients with hemodynamic impairment, mortality rates approach 20. Pathogenesis involves venous stasis, alteration in coagulation, and vascular injury. Risk factors. Hereditary thrombophilias. Prothrombin 20,210 G and GTA variation. Hyperhomocysteinemia. Genetic abnormalities. Nutritional deficiencies of vitamins, B6, B12, folate. Clinical disorders, renal insufficiency, hypothyroidism, inflammatory bowel disease, dysfibrogeninemia, familial plasminogen deficiency, protein C deficiency, protein S deficiency, factor antithrombin 3 deficiency, factor V Leiden mutation. Most common of the inherited thrombophilic conditions. Appears to be an important risk factor for venous thromboembolism during pregnancy, in the postpartum period, and during oral contraceptive use. Acquired surgical predispositions. Major thoracic, abdominal, or neurosurgical procedures requiring general anesthesia and lasting &GT 30 minutes, hip arthroplasty, knee arthroplasty, knee arthroscopy, hip fracture, major trauma, open prostatectomy, spinal cord injury. Acquired medical predispositions. Prior venous thromboembolism, advanced age, &GT 60 years, malignancy, congestive heart failure, cerebrovascular accident, nephrotic syndrome, post-Rogan therapy, pregnancy and the postpartum period, obesity, prolonged immobilization, antiphospholipid antibody syndrome, lupus anticoagulant, paroxysmal nocturnal hemoglobinuria, Behçet's syndrome. Clinical presentation. Swelling, pain, erythema, warmth. Classic findings include Hohmann's sign, Moses sign, palpable cord. Differential diagnoses include arthritis, muscular injury or tear, neuropathy, arterial insufficiency, lymphoedema, ruptured Baker's cyst, superficial thrombophlebitis, chronic venous insufficiency. Diagnosis. Contrast venography. Most reliable criterion. Venous thrombosis is a constant intraluminal filling defect evident in 2 or more views. Other criteria: non-visualization of deep veins, venous collaterals, or non-constant filling defects, less reliable. High sensitivity and specificity. Not easy to interpret, especially in patients with a prior history of venous thrombosis. Venous cannulation may often be difficult, especially in the presence of edema. Venous thrombosis may be induced by the procedure itself. The cost, invasive nature, and discomfort of the study make sequential studies impractical. Duplex ultrasonography refers to the combination of Doppler venous flow detection and real-time B-mode imaging. Assumed a central role in the non-invasive diagnosis of symptomatic lower extremity deep vein thrombosis. Most reliable criterion is the non-compressibility of a venous segment. Less reliable criteria include presence of echogenic material within the venous lumen, venous distension, loss of phasicity, response to Valsalva maneuvra, augmentation of spontaneous flow. The absence of an echogenic luminal mass cannot be considered useful in excluding the diagnosis of venous thrombosis because acute thrombus may not demonstrate echogenicity. Sensitivities and specificities exceeding 95% in symptomatic patients with proximal venous thrombosis. A more prudent approach appears to be a complete examination extending from the inguinal ligament to the popliteal vein and examination of the contralateral extremity if thrombus is detected in the symptomatic leg. Less accurate in the detection of symptomatic calf-limited thrombi, sensitivity 70%, and in asymptomatic proximal vein thrombi, sensitivity 50%. Limited utility as a screening study in high-risk populations. Implantsplethysmography. Indirect technique that measures the rate of venous outflow. False positive studies from conditions that diminish arterial inflow, CHF, shock, PAOD, or that impede venous return, RVF, COPD, which lowers the specificity of the technique. Early studies reported sensitivities of approximately 90% in symptomatic patients with proximal venous thrombosis. Magnetic resonance imaging. As sensitive and specific as duplex ultrasonography. A potential advantage is that the entire length of the venous system, including the pelvic veins, is imaged. Disadvantages include cost and limited access of the machine as well as the expertise required to properly perform and interpret the studies. Computed tomography venography. Role is limited. Sensitivity and specificity are comparable to ultrasonography but mandate contrast injection with its associated risks and radiation exposure. Potential advantage includes the ability to visualize the pelvic veins and vena cava. A diagnostic approach combining it with computed tomography pulmonary angiogram may have a role in patients undergoing evaluation for pulmonary embolism. Hemostasiologic assays. D-dimer. Highly sensitive but not specific. Positive in advancing age, pregnancy, trauma, infections, the postoperative period, inflammatory states, and malignancy. Fibrin monomer. Prothrombin fragment. Thrombin antithrombin 3 complex. Fibrinopeptide B. Fibronectin. Clinical prediction rule. A post-test probability that can be utilized as a basis for clinical judgment, either excluding the disease with a certain level of probability, confirming the disease with a certain level of probability, or supporting the need for additional diagnostic testing. Useful in era of non-invasive testing in which results are often presented as probabilities rather than as discrete answers. Wells rule. 3 probability categories are low, 3%, moderate, 17%, and high, 75%. By utilizing this prediction rule in combination with lower extremity ultrasound, venous thrombosis can be excluded in patients with a low clinical likelihood of venous thrombosis in combination with a negative lower extremity ultrasound and confirmed in patients with a high clinical probability and a positive lower extremity ultrasound. Dramatically reduces the need for contrast venography or serial lower extremity ultrasound studies. A score of and LT2 means that a diagnosis is unlikely, while a score of superscript 32 means that a diagnosis is likely. Pulmonary embolism background. Generally, a complication of venous thrombosis that can induce a series of pulmonary and cardiac effects. Causes several consequences to gas exchange and other pulmonary functions. If regional pulmonary vascular obstruction is total, alveolar dead space is created. Embolic occlusion increases pulmonary artery pressure. Massive embolic events increase right atrial pressure leading to intracardiac right to left shunting through a patent foramen ovale. Final mechanism for hypoxemia is loss of pulmonary surfactant leading to atelectasis and edema. One uncommon local consequence of pulmonary embolism is pulmonary infarction, which occurs in approximately 20 to 33% of patients with significant cardiac or pulmonary disease that compromises either bronchial arterial flow or airway patency. In patients with left ventricular failure, increased pulmonary venous pressure may decrease bronchial flow and infarction may result. The cardiac and hemodynamic effects of embolism are related to 3 factors. The degree of reduction of the cross-sectional area of the pulmonary vascular bed. The pre-existing status of the cardiopulmonary system. The physiologic consequences of both hypoxic and neurohumorally mediated vasoconstriction. Recruitment and distension of pulmonary vessels occur. Cardiac output is maintained by increases in the right ventricular stroke volume and increases in the heart rate. The Frank-Starling mechanism maintains right ventricular stroke work and cardiac output. Severe pulmonary hypertension may develop in response to a relatively small reduction in pulmonary artery cross-sectional area. Clinical features. The presentation can be categorized into one of 3 clinical syndromes. Isolated dyspnoea, pleuritic pain or hemoptysis. Circulatory collapse. The most common presenting symptom of acute embolism is sudden onset of dyspnoea. Other symptoms include cough, leg swelling, and leg pain. The most common physical finding is unexplained tachypnoea. Clinical findings noted less frequently include crackles, tachycardia, increased pulmonic component of the second heart sound, fever, and hemoptysis. Diagnosis. Standard laboratory evaluation. Provide valuable adjunctive information and support for therapeutic interventions and may confirm the presence of an alternative diagnosis. Chest radiography. Abnormalities are usually subtle, nonspecific, and therefore non-diagnostic. The most common radiographic abnormalities are atelectasis and pulmonary opacities, which can be of any shape, not necessarily wedge-shaped. Pleural effusions occur in almost half of the patients. Most effusions are small and involve only blunting of the costophrenic angle. Other findings include Westermarck sign, focal areas of avascularity, Hampton hump, pleural-based, wedge-shaped density, Fleischner sign, Prominence of the central pulmonary artery. Electrocardiography. Nonspecific tachycardia. T-wave inversion and abnormalities of the ST segment. Classic findings of right heart strain, including an S1Q3T3 pattern, a pseudoinfarction pattern, a complete or incomplete right bundle branch block, or right axis deviation. Arterial blood gas analysis. Helpful but not definitive. Arterial hyposemia may be present, and the more massive the obstruction, the more severe the hyposemia is likely to be. Many other conditions also cause hyposemia, and embolism often does not cause hyposemia or even a widening of the alveolar. Arterial PO. Difference. Hypercapnoea appears with embolism only in patients with marked antecedent ventilatory limitation. Echocardiography. Valuable role in the diagnosis of pulmonary embolism. Detection of unexplained right ventricular volume or pressure overload might suggest the possibility of embolism. Distinct echocardiographic involving akinesia of the midfree right ventricular wall with apical sparing has been described. Transoesophageal echocardiography has demonstrated excellent specificity for the detection of proximal emboli that involve the pulmonary trunk and the right and left main pulmonary arteries. Overall sensitivity of transthoracic echocardiography in pulmonary embolism approximated 50%, cannot be considered a primary diagnostic technique. Biochemical markers for evaluating the prognosis and right ventricular function of patients with embolism include serum troponin and brain natriuretic hormone levels. Ventilation perfusion scanning. Valuable step in the diagnosis of pulmonary embolism if it is interpreted appropriately. A negative study rules out the diagnosis of pulmonary embolism with the same degree of certainty as a negative pulmonary angiogram and with a higher degree of certainty than is achieved by a negative computed tomography scan. Diagnostic yield is about 87%, but the positive predictive value rises to 96% when coupled with a high clinical probability. To improve perfusion scan specificity, rely on the number and size of the perfusion defects as well as on the results of a concurrent ventilation image. Intended basis for doing so is to differentiate pulmonary vascular obstruction, mismatched defects, from primary parenchymal disorders that result in compensatory pulmonary vasoconstriction, matched defects. Diagnostic approach to pulmonary embolism in patients with underlying chronic obstructive pulmonary disease remains problematic because pulmonary embolism may closely mimic an exacerbation of their underlying disease. Spiral, helical, computed tomography represented a major advance in pulmonary embolism diagnosis. Provides the ability to directly visualize emboli as well as to detect parenchymal abnormalities that may support the diagnosis of embolism or provide an alternative basis for the patient's complaints. Sensitivity is 57 to 100% and specificity is 78 to 100%. Inherent limitations include: requires infusion of intravascular iodinated contrast agents. Certain areas such as the hila are prone to false positives. Cannot differentiate between chronic and acute venous thromboembolism. Can expose patients to clinically significant doses of radiation. Younger women, who have a known elevated incidence of pulmonary embolism, are particularly at risk from radiation damage to breast and lungs. Lower extremity venous evaluation. Because most pulmonary embolisms arise from deep veins of the lower extremities, the detection of lower extremity proximal vein thrombosis in a patient suspected of embolism is strongly suggestive of that diagnosis. Lower extremity ultrasonography has a very low yield in patients without leg symptoms or risk factors strongly suggestive of thromboembolism. Positive in only about 10 to 20% of patients with suspected embolism and in 50% of patients with proven embolism. D-dimer testing. Its utility is limited by the same shortfalls as those encountered in venous thrombosis pathways. A low specificity makes it most useful as an exclusionary technique in outpatients and a lack of standardization. Normal result can safely exclude embolism in patients with a low clinical probability of disease. More reliably applied in suspected pulmonary embolism with a low risk score on Wells rule and positive on the pulmonary embolism rule-out criteria. A negative D-dimer in this setting effectively rules out pulmonary embolism, while a positive result requires further imaging evaluation. Pulmonary angiography. Capable of excluding or confirming the diagnosis of embolism in most patients with suspected embolism. Angiography should be considered in patients in whom the diagnosis has not been confirmed or excluded using non-invasive techniques, and when it is considered unsafe to withhold anticoagulation. Can be performed quite safely if certain safeguards are observed and experienced personnel are involved. Interpretation is heavily influenced by three factors: location of the thromboembolic obstruction, quality of the images, experience of the interpreters. Only 2 angiographic findings are diagnostic of acute embolism. Filling defect, abrupt cut-off of a vessel. Clinical prediction rules include Wells score, modified Wells score, simplified Wells score, revised Geneva score, Charlotte rule, pulmonary embolism rule-out criteria, PERC. Wells score and PERC rule are the most validated. Wells rule. Same as deep vein thrombosis but follows an algorithm to prevent unnecessary imaging in an otherwise low-risk patient. Applied first in a suspected pulmonary embolism patient. PERC rule. Applied after Wells rule in a low-risk patient. More reliably rules out pulmonary embolism if negative in a low-risk patient. Not validated for people with active cancer, thrombophilia, or a strong family history of thrombophilia. Transient tachycardia or beta blocker use that may mask tachycardia. Leg amputations. Morbid obesity, baseline hyposemia when oximetry reading of NLT 95% is long-standing. Venous thromboembolism, management. Anticoagulant therapy for proximal deep vein thrombosis and pulmonary embolism. Anticoagulation is the recommended treatment unless there is an absolute contraindication. Requisite investigations include activate partial thromboplastin time, international normalized ratio, full blood count, kidney function, liver, biochemistry, and beta human chorionic gonadotrophin. 4. Reproductive age women. Oral anticoagulant, oral anticoagulant, either warfarin or non-vitamin K oral. Anticoagulant, can be used for most patients but are not first-line therapy for venous thromboembolism in pregnancy or for cancer. Associated venous thromboembolism. Warfarin or parenteral anticoagulant is the oral anticoagulant of choice for patients with renal impairment. Oral factor XA inhibitors, example apazaban, rivaroxaban, are preferred to dabigatran or warfarin because they do not require parenteral anticoagulation for initiation. Apazaban 10 mg orally twice daily for 7 days, then reduced to 5 mg twice daily, or rivaroxaban 15 mg orally twice daily for 21 days, then reduced to 20 mg once daily. In general, non-vitamin K oral anticoagulants are contraindicated if the creatinine clearance is and LT 30 ml/min, and LT 25 ml/min for apazaban. If using dabigatran, parenteral anticoagulation should be given for 5 days prior, the first dose given at the supposed scheduled time of the parenteral anticoagulant, or up to 2 hours before this. Dabigatran 150 mg orally twice daily if and LT 75 years and creatinine clearance and GT 50 ml/min, or 110 mg orally twice daily if and LT 75 years and creatinine clearance 30 to 50 ml/min, or increased risk of major bleeding, or 110 mg orally twice daily if superscript 375 years and creatinine clearance and GT 30 ml/min. If using warfarin, parenteral anticoagulation should be given concurrently, at least initially. Warfarin started alone is associated with high rates of thrombus extension. Parenteral anticoagulation is given for a minimum of 5 days, and until the international normalized ratio is above 2:2 consecutive days, and then warfarin alone. International normalized ratio is 2:3. For parenteral anticoagulation, use either dalteparin 2, creatinine clearance superscript 330 ml/min, units/kg subcutaneously, once daily, or 100 units/kg twice daily, or enoxaparin 1.5 mg/kg subcutaneously once daily, or 1 mg per kilogram twice daily. 4. Creatinine clearance superscript 330 ml/min, or 1 mg per kilogram subcutaneously, once daily if creatinine clearance is and LT 30 ml/min. Twice daily dosing of dalteparin or enoxaparin may be preferred for patients at high risk of bleeding, extremes of weight, concurrent malignancy. Unfractionated heparin 80 units/kg intravenous loading dose followed by 18 units/kg/hour by infusion adjusted to according to activated partial thromboplastin time, used for patients with severe renal impairment or those at high risk of active bleeding that may require rapid reversal of anticoagulation. Unprovoked distal deep vein thrombosis, proximal deep vein thrombosis and pulmonary embolism due to a major provoking factor, example major surgery, hospitalization with immobilization, estrogen therapy, and pregnancy and the postpartum period, that has been treated or reversed requires anticoagulation for 3 months. For patients with isolated distal deep vein thrombosis caused by a major provoking factor that has been treated or reversed requires anticoagulation for 6 weeks. The decision to extend anticoagulation beyond the recommended period depends on the balance between bleeding and thromboembolism risk, fibrinolysis and interventional treatment for venous thromboembolism. Treatments for hemodynamically unstable pulmonary embolism include systemic fibrinolytic therapy, catheter-directed fibrinolytic therapy, thrombus aspiration, surgical thrombectomy and the use of extracorporeal membrane oxygenation. Options for systemic fibrinolytic therapy include alteplase or tenecteplase, followed by parenteral anticoagulation with dalteparin or enoxaparin or unfractionated heparin, if with renal impairment or high risk for bleeding. Graduated compression stockings providing 30 to 40 mmHg pressure from the ankle to just below the knee reduce the risk of post-thrombotic syndrome.